This is our session one, and we are very, very fortunate to have Dr. Murali with us to give the first talk. And of course, we are very fortunate to have him in the forum and as a TMC alumni with all this brilliance. I want to say, before I say any few words, but first I want to ask our captain, sir, to speak a few words about Dr. Murali and, his impressions and, to everyone in TMC. Captain, sir, please.
So I started it from the note only. I know Murali from his fourth year MBBS. Such a brilliant boy I have never seen in my teaching experience. Sorry for others also, equally good with my contact, direct contact with him. And he is not restricted. Hello?
Yes, sir.
He is not restricted to endocrinology alone. He knows all medicine. He can talk anything on earth. So God should give him a long, prosperous life to serve this nation and humanity in general. I wish him and bless him a long, long, long life. Thank you all very much.
Thank you, Captain, sir. And I now request Dr. Rafiq to say a few words about Dr. Murali.
So it's an honor to say something about Murali. I know Murali since college days only. Had I known him before in Trichy, it would have been more of a benefit. I had the pleasure of driving him now recently from Trichy to Tanjore, and that was the best hour in my life. I think that tells it all. Thank you.
All right. So thank you, Dr. Rafiq. And so I just add a couple of sentences and then we'll give the stage to Dr. Murali, to inspire us. So Dr. Murali was, my teacher in addition to, TMC and then, in PJ Chandigarh, and where I witnessed his brilliance, on the bedside and, in the clinic and as well as in the clinical pathological forums, and easily the most knowledgeable person I would have met, in my career. And so we are very, very fortunate. And probably the best thing about Dr. Murali is not only his breadth and width of knowledge, but his amazing clinical skills. So you combine all of that together and his humbleness and his ability to teach. If you put all of that together, it's a very, very rare to see all of them together in one person. So we are indeed very, very fortunate to have him with us. Dr. Murali, I want to pass it on to you now to enlighten us. And Dr. Venkatesh will take over from here. Thank you.
Thank you. May I start?
Yes, sir.
Yeah. This is a topic very dear to my heart, and when it was proposed, I must give compliments to Dr. Venkatesh for carrying forward the thoughts and the desire of the whole TMC case conference group to host a Zoom meeting so that our younger lot will be benefited. The students, first he started with career options in different countries, and this is the first talk where we are going to kickstart the scientific meetings of the TMC case conference group. And so I chose this talk because this is a very often discussed topic. I don't know why it's not moving. Yeah. It's often said that clinical medicine is becoming extinct, especially nowadays. Maybe it's considered a thing of a generation gap, and at least my daughters feel so about me because I've crossed 60. But if you look at this, Machiavelli said more than 500 years ago that men ever praise the olden time and find fault with the present, though often without reason. Endocrinology has always been a clinical specialty right from the beginning, even though now we may think it's more a lab investigation oriented specialty. This was pictured in 1878, a patient of myxedema, the pre-morbid picture, and then how the disease evolves, the characteristic clinical picture at the age of 21 before onset of symptoms, 7 years later, and 11 years later. And like in every other branch of medicine, like neurology, the pioneers of clinical endocrinology, because at that time hardly any lab investigations were available, they meticulously recorded the clinical signs and symptoms of patients, clubbed them together, found a pattern, and then described various syndromes which are named eponymously after them. Some examples I've quoted here: Addison, Cushing, Kohn, who was the father of secondary hypertension, describing the hyperaldosteronism, and Albright, who is the father of bone and mineral endocrinology, where he first described not only the hyperparathyroidism bone disease, but also a rarer form of disease, what is called hormone insensitive state. Pseudo hyperparathyroidism was the first condition described by him, just based on clinical stigmata. Not just clinical, comparing to many other specialties, endocrinology actually was the pioneer in therapeutics also. In 1891, much before, that is 3 decades before the famous celebrated discovery of insulin by Banting and Best was introduced, Murray in 1891 gave thyroid extract successfully to a myxedematis patient and cured her. And in 1913, pituitary extract for diabetes insipidus was already in use by Farini and van der Velden. So coming to think of it, even before hormone assays were discovered, the therapeutic endocrinology started, culminating in the Nobel Prize winning discovery of insulin by Banting and Best and its first human use in 1922. So what is important to recognize is that the first case of myxedema treated with thyroid extract, it was all based on clinical signs and symptoms, and then they thought, based on some animal experiments, that thyroid is the organ involved, and the patient was thus enabled by regular and continued use of thyroid extract to live in good health for over 28 years, from 1891 till 1919. And this was published in 1920 by Murray, the life history of the first case of myxedema treated by thyroid extract. And what he observed was the thyroid is purely an internal secretory gland, and the symptoms of myxedema can be entirely removed. Then endocrinology exponentially evolved. Coming to think of other branches of subspecialties of medicine, we may call modern endocrinology a relatively young specialty. It borrowed heavily, embraced, and was helped largely by organic chemistry, physics, nuclear science, radiology after the early 20th century discovery of radioactivity, then immunology, then in recent times by genetics, molecular biology, cybernetics, and the recent kid on the block, artificial intelligence. So in that way, endocrinology has embraced every specialty and has become richer because of that. As the advances in laboratory have increased, endocrinologists are faced with a unique situation where we see largely many subclinical endocrinopathies, which can be functional alterations, where it could be a subclinical hyperfunction of a gland or a subclinical hypofunction of a gland, which are subtle functional alterations not associated with well-recognized symptoms and clinical signs of respective hormone dysfunction. This could be a preclinical stage in the evolution of the disease detected early by lab investigation. In addition to that, with the increasing use of imaging, first starting with ultrasound and then CT scan and MRIs, we have come to recognize another important entity. Initially, first introduced, this term has been introduced by endocrinologists only, what are called incidentalomas, where incidentalomas of adrenal, thyroid, pituitary, you find on imaging done for some other purpose. You just get an abdominal ultrasound or a CT for abdominal pain and you find an adrenal nodule, which is an adrenal incidentaloma. Why this increase or burgeoning increase in the detection of subclinical endocrinopathies is because of increase in use of lab tests, especially thyroid function tests are now available in every package. Serum calcium, 25-hydroxyvitamin D, testosterone, they are increasingly used because of sensitized medical community as well as health conscious patients, perception that routine preventive health packages are useful and aggressive promotion by labs, all these tests are being done routinely in annual health packages or sometimes more frequently also. An increase in use of imaging modalities, as I had already told you, revealing incidental mass of adrenal, thyroid, pituitary, etc. As the technology has evolved, akin to what we see in IPL, this is the IPL season, so we have to take analogy from that. More and more, the patients feel, as well as the medical care providers feel, that technology, if it's available, why can't we use it to our advantage? So just like an on-field umpire goes upstairs, or the teams themselves have DRS to ask for a player review from the third umpire, the technology has increasingly been playing a role in our decision making. So that's why subclinical endocrinopathies is an entity we often face, especially the well-characterized entities of subclinical thyroid disease. We often face questions in any conference about subclinical hypothyroidism. Then there is a large entity called asymptomatic hyperparathyroidism, where just on routine testing we find high calcium, and then on further testing they have parathyroid hormone elevation, but without any signs or symptoms of hyperparathyroidism. We have entities of subclinical Cushing's, subclinical pheochromocytoma, and much more common but controversial entities of vitamin D deficiency and testosterone deficiency, which are picked up by lab testing. So because of such wide use of lab tests and the imaging, the clinician's role has increased manifold. We have increased responsibility for appropriate interpretation of the test results and formulating decisions for further management, follow established guidelines for active treatment or close observation with follow-up, and optimum counseling of a patient to allay anxiety, and treat the patient as a whole, not the lab result. So coming to what is the anatomy of clinical reasoning, this doesn't apply to endocrinology alone, this applies to every branch of medicine. A good clinician, an experienced one at that, first looks at the patient clinical story, the symptoms, signs, based on a history, based on pattern recognition from his past experience, and also the pre-test probability of that particular disease in the population, how common that disease is. Then uses what is called Occam razor, that trying to fit all the available signs and symptoms to limit to as less number of diseases as possible. That is trying to fit everything together to diagnose one disease. Correlation with available test results, find alternate explanations for inexplicable outlier, so that you try to find out finally what the diagnosis is. More often we succeed in this attempt. So this is how we have been learning clinical approach right from our early clinical days, from Hutchison Hunter, chief complaint, clinical assessment, history of past illness, the physical examination, then preliminary screening tests. This is actually taken from an emergency book approach, where we make some decision whether to discharge the patient or the patient needs further tests, imaging, consultation, admission, and then finally discharge the patient based on the final diagnosis which we have reached. Coming to look at the problem in a much more refined manner, we first try to identify the problem. For instance, a patient presenting with breathlessness on exertion. Frame the differential diagnosis in a way that facilitates recall, whether it is cardiac, pulmonary, or it is some systemic disease like anemia, which makes him breathless. Organize the differential diagnosis into clinically useful subgroups, and then systematically work through the differential diagnosis. If it is cardiac, whether it is ischemic, whether it is some myocardial dysfunction like cardiomyopathy. If it is pulmonary, whether it is obstructive, restrictive. So the DDs come in there. Then limit the differential by using pivotal points to create patient-specific differential. That is based on the age of the patient, gender of the patient, habits, family history, past history, and then explore the patient-specific differential using history and physical exam findings so that we rank the differential diagnosis and find out what is the leading hypothesis, what is the must not miss hypothesis, and what are the additional active alternate hypotheses. For the students, I suggest this book. It's a very beautiful book, Symptoms to Diagnosis, an evidence-based guide, how to approach a clinical problem. Once we have ranked the differential using the results of exploration, we select the leading hypothesis. That is how we work on. This is the most likely diagnosis, and then we work up according to that. The most important is select the must not miss hypothesis, which diagnoses are life threatening and must not be missed so that we do not end up in any catastrophic outcome for the patient. And select alternative hypotheses, which are also active. And then based on this, we test the hypothesis based on which tests have very high likelihood ratios and can rule in a disease, and which tests have low likelihood ratios and can rule out a disease. This itself is a separate topic. I think we can have a seminar on this at a some other time, where how to interpret lab investigations, what is the sensitivity, specificity, etc. Once the diagnosis is confirmed, we treat. If still not confirmed, we re-rank the differential based on new data which are emerging. So it's a dynamic process. It is not that it is a one-way process. A clinician always oscillates to and fro between different possibilities. New data emerge. Some lab investigations which were pending now comes, which changes our hypothesis. So finally, the diagnosis is our goal, and because our treatment is based on the diagnosis. So strategies in decision making, they are basically on pattern recognition, rule out worst case scenario so that we avoid any morbidity or mortality for the patient, and a method called exhaustive method, where we extensively investigate the patient. Unfortunately, nowadays, this is practiced because of widespread use of lab tests and panels. Patients come to us already with a set panel of investigations. The other thing is what is called a hypothetico-deductive method, which any clinician should be fond of, how to selectively investigate a given patient so that we can make it cost effective. In these strategies, two major things come in which can be useful to the clinician, but at the same time can be detrimental because they introduce bias into clinical reasoning. These are called heuristics, and the other thing is called cognitive disposition to respond. The simpler term for cognitive disposition to respond is bias, but because bias is pejorative, this term is used by cognitive psychologists now. In fact, I should tell you that cognitive psychology is now a very important field in helping clinicians to think how they are thinking. This is called metacognition. Most of the time, we think and we make diagnosis subconsciously, even without analyzing how we are doing it. But now cognitive psychologists have given us this path where we know how the clinical thinking process happens, where the error occurs, and where we can improve. So as I told you, heuristics, biases, beliefs, expectations, motives, dispositions to respond, and priming effects. These are the various things which influence how a clinician will take a decision to arrive at solution of a clinical problem. Normal thing which we expect is what is called a top-down processing, where based on your knowledge, based on past experience, based on a systematic analysis, you analyze a case. Sometimes it is not possible. You get a lot of data in the beginning itself, and you go what is called bottom-up processing. This is data-driven. So based on the data, you retrospectively work backwards to arrive at a diagnosis. Finally, any clinician uses a combination of both top-down and bottom-up processing to solve a clinical problem and then arrive at a decision making. This is just an exercise in bottom-up approach. As endocrinologists, many a time it is thought that we can make diagnosis over the telephone. Some colleague or a medical officer from emergency will just call us in the middle of the night and give you this test results or send it by WhatsApp. This was a patient, 50-year-old male, fasting 599, PP 720, admitted in ER with obtundation. Sodium 128, potassium 6, chloride 103, but the creatinine is only 1.2. So in a bottom-up process, immediately our mind has to work to find out what is the cause of this hyponatremia and hyperkalemia. Immediately we'll think whether it is adrenal insufficiency, but it's not. Look at the blood sugar values. With such high blood sugar values, this hyponatremia is artifactual. It's called translocational hyponatremia. We need to go for a correction. I'm not going into the details now, so that actually the patient is not hyponatremic, but definitely there is hyperkalemia, which is out of proportion to the serum creatinine. So then you ask the history from the medical officer whether the patient is on ACE inhibitor or ARB, and in a patient who is 50-year-old, diabetic, long-standing, whether there is an underlying hyporeninemic hypoaldosteronism. All these thoughts will cross your mind, and you will ask relevant questions to the medical officer within the next 1 or 2 minutes, and then order relevant investigations. So how the clinician thought process works is of two types. One could be a blink. Malcolm Gladwell has written a beautiful book on blink, which is an intuitive process of arriving at any decision. So most clinicians look at this blink approach in the form of pattern recognition or instant hunch diagnosis. In German, it's called Augenblick diagnose. There are 2-3 papers on this in neurology. There are many specialties which are amenable to this type of diagnosis, like dermatology, for instance. If you know it, you know it, otherwise you don't know it. The typical appearance of the lesion will give you the diagnosis. Whereas the other approach, which is a systematic approach, is given by this book. The other day we discussed this in our case conference group, the Nobel Prize winning Daniel Kahneman's book, Thinking Fast and Slow, where how the human brain has been characterized to have two systems. The system one, which is rapid, instant making decisions in a blink, what is called the intuitive part of the brain, and the other part of the brain, which is more analytical, slow thinking. And finally, it is the slow thinking which is important for a proper decision making. And many a time, we may do errors on only a blink diagnosis. This is Augenblick diagnosis. This is a beautiful article. You can note down Seminars in Neurology 98, where they have given examples of several diseases which can be diagnosed in a blink. So clinicians use heuristics often. What are heuristics? Heuristics are simple, efficient rules which people often use to form judgments and make decisions. They are mental shortcuts that usually involve focusing on one aspect of a common problem and ignoring others. So heuristics can be useful in situations to cut short your time, but at the same time, they can be detrimental because they are one of the important reasons for clinical bias. Common heuristics in clinical practice, which have been passed on from generations. Our professors have also taught us this. If it looks like a duck, sounds like a duck, and walks like a duck, it is a duck. Common conditions are more common than what they are. They are much more common. Don't try to diagnose uncommon conditions when you have common possibilities. If you hear hoofbeats, don't think zebras. Look for a single diagnosis that can explain all the findings, what is called Occam's razor. I'll explain each of these subsequently. Favor a diagnosis or choose diagnostic investigations that explains the clinical findings or are most likely to verify diagnosis. This is called Sutton's law. Go where the money is. Sutton it's an apocryphal story where he was a robber who robbed a bank, who used to rob banks. And when the judge asked him, why are you robbing banks? He said, that's where the money is. So going for where the money is called Sutton's law. That is trying to find out which is the most plausible explanation for all the patient's symptoms. As far as therapeutics is concerned, these are the heuristics. First, do no harm, treat the patient, not the numbers. Many of them done in good faith, but sometimes they can lead to bias. So this is one of the heuristic, whether it is a goose or a duck. Another thing is finding zebra amidst horses. All of us in our practice sometimes see rare diseases, but it's always a tricky proposition. If you are specializing in a very narrow, focused niche area, you are prone to develop what is called a zebra bias. Like one of my teachers was an expert in vaginous granulomatosis, and for him, every cavity lung lesion, he will keep that possibility as the first diagnosis. As in therapeutics, for instance, somebody who is a shoulder surgeon and any shoulder pain, he may always think that he's a candidate for a shoulder surgery. If all you have is a hammer, everything looks like a nail. But the converse is also true. There are clinicians who have the subconscious fear not to diagnose rare diseases, so they avoid uncommon diagnosis. This is called zebra retreat. So good clinician has to be wary of both. You should try to find out the zebra amidst horses whenever the clinical presentation is atypical or the pointers are pointing to something rarer. Otherwise, we will not be diagnosing rarer diseases at all. We will keep on looking at only common diseases. Now coming to Occam's razor, which is a very important dictum we always try to follow. This is called lex parsimoniae in Latin, which means law of parsimony. This is a problem solving principle which is attributed to William of Ockham, who was an English friar and scholastic philosopher and theologian who lived from 1287 to 1347. And this principle can be summarized as among competing hypotheses, the one with the fewest assumptions should be selected. In clinical medicine, it's called parsimony in diagnosis. Parsimony means you are thrifty or you use as few possibilities as possible. Examples, common examples will be if a patient of congestive cardiac failure has jaundice, you will think of congestive hepatopathy and not viral hepatitis. In a post-operative fever, you will always think of a surgical site infection or a UTI because of bladder catheter, not leptospirosis or malaria. But there are exceptions to this, like I'll tell you subsequently with case witness. So let's start with our case witness to illustrate whatever theory I spoke on clinical decision making. And I think that this will be useful for our medical students who have joined. MM is a 38-year-old businessman, was detected to have diabetes 1 year ago while on investigation for difficulty in climbing stairs, getting up from squatting, numbness, and paresthesia. Treated by a neurologist as diabetic neuropathy and amyotrophy. Family history of diabetes in father. He was overweight. BMI was 27.8. The fasting was 180, postprandial 245. He was given gliclazide, metformin thrice a day by a physician. For the last 6 months, he had multiple somatic symptoms, constipation followed by intermittent diarrhea, depression, and insomnia, seen by psychiatrist and prescribed amitriptyline. He lost 18 kilograms weight due to anorexia and diarrhea. He was seen by a gastroenterologist. Berry meal follow through was normal. Endoscopy was non-specific gastritis and duodenitis. He was treated symptomatically and labeled gastritis plus irritable bowel syndrome. He had pruritic skin lesions on abdomen and inner aspect of thighs with discoloration of nails, treated with topical creams with no relief. History of ingestion of multiple over-the-counter medications. He is a chronic smoker, recently abstinent. History of cough with intermittent expectoration but no fever. He presented to my outpatient with generalized weakness, worsening of difficulty in walking and getting up from recumbency and squatting. He was off gliclazide for a week. His blood sugar was uncontrolled. He was hypertensive. He had intermittent cough but was afebrile. The chest showed scattered rhonchi. There was vague costal pain while coughing. This was the picture of the patient. Looking at his face, something struck. These were the nails, many affected by onychomycosis. The feet also, toenails. The abdomen, compared to the face, which looked slightly plethoric, he had only pale striae. We didn't have the typical violaceous, broad striae with atrophic skin, which we expect in a Cushing. But I investigated him for fasting 167, PP 220, LFT and renal functions were normal. He had hypertriglyceridemia and mild LDL rise. I went for investigating his cortisol status. Cortisol 8 a.m., 4 p.m. both were high. There was no circadian variation. 10 p.m. cortisol was also high. His ACTH was less, 10 picogram per ml. The overnight dexamethasone suppression test showed lack of suppressibility, confirming that it is Cushing. And a high dose dexamethasone suppression test again showed that it is not suppressed, thereby meaning that we are dealing with an ACTH independent Cushing because ACTH is also suppressed. So went for imaging. It was a left adrenal adenoma, which is quite large, 3 into 4 centimeters. Again shown in this. And we had a CT chest also because he had cough with expectoration, and it showed a cavitary lung lesion, and which was AFB positive. He had pulmonary tuberculosis also. So there were several learning points which emerged from this patient. Diseases unfold their diagnosis in casual parenthesis. This is a very famous quote. And this patient is a fit case for Occam razor. He had diabetes, he had proximal muscle weakness, he had depression with plethoric phase, all raising suspicion of hypercortisolism. He had onychomycosis and pulmonary TB, known complications of hypercortisolism. He had history of OTC medications. So initially I thought we could be dealing with an iatrogenic Cushing, but once we got the cortisol levels, it was clear that it was an endogenous Cushing, and it was ACTH independent endogenous hypercortisolism due to adrenal adenoma. The adrenalectomy was done by the surgeon promptly. It was rewarding, reversed most of his problems. His diabetes well controlled on only metformin 500 milligram twice a day. The case with a 2. This is a 38-year-old businessman, known type 2 diabetes of 3 years duration, well controlled till recently on Verchase, presented with obtunded sensorium last 24 hours. On detailed history, polyuria, polydipsia last 48 to 72 hours, dry cough last 2 weeks, back pain generalized takes 3 to 4 months, treated by an orthopedic surgeon with some injections 2 weeks ago, no fever. He looked clinically dehydrated, drowsy but arousable, no focal deficits, neck was supple. He was quite well till recently, except for the back pain that was diagnosed as spondylitis. No ketonuria, no acidosis. Plasma glucose at admission was 280, sodium 138, potassium 4.2, blood urea nitrogen showed 52, his creatinine was 2.6. But there is a history, the past story, his creatinine 2 months ago was only 0.9 and the CBCs were normal. This was the chest X-ray, which immediately made us suspect bilateral hilar prominence was there. A chest CT, HRCT showed bilateral paratracheal hilar and few periaortic lymphadenopathy. So based on this, we started suspecting sarcoidosis and investigated accordingly. His calcium was 12.2, phosphorus 3.6, albumin 3.4. So corrected calcium was still higher. The 25-hydroxy D surprisingly was 162 because in sarcoidosis, we expect the 125 dihydroxy vitamin D, that is calcitriol, to be high because these granulomatous cells, they produce the 1-alpha hydroxylase, which causes increase in synthesis of calcitriol. So once 25-hydroxy levels are high, it means that he has been taking exogenously high dose of vitamin D. His PTH was appropriately suppressed, which means it is a PTH independent hypercalcemia. So the diagnosis was sarcoidosis with hypercalcemia, which was aggravated by iatrogenic vitamin D toxicity. Because sarcoidosis, as you all know, is a vitamin D hypersensitive state because of the granulomatous cells which have high 1-alpha hydroxylase activity. This was an acute hypercalcemic crisis with acute kidney injury and metabolic encephalopathy. There were several learning points from the case. There were 2 exceptions to Occam razor in this patient. Hyperglycemia was the presenting manifestation, but that was not the cause of encephalopathy in this patient because his sugar was less than 300, he was not hyperosmolar, he didn't have ketonuria, and in hyperosmolar state of decay or hyperosmolar coma. It is the hyperosmolarity which is the cause for the obtundation in sensorium. Actually, in this patient, it was hypercalcemia which is responsible for the sensorium change. And hypercalcemia had more than one etiology in this patient, sarcoidosis as well as iatrogenic vitamin D overdose. So correlation of different points in history, examination and labs were important to knit a cogent diagnosis in this patient. Encephalopathy, non-oliguric acute kidney injury, and hilar adenopathy with hypercalcemia suggested a granulomatous disorder like sarcoidosis. History of injections and elevated levels of both 25-hydroxy-D and 125-dihydroxy-D showed a dual etiology of hypercalcemia. When we asked the patient, he brought back the prescription of the orthopedic surgeon who had given him 6 lakh units of vitamin D, araquitol. He had advised him once a week for 4 weeks. The patient had taken every day for 1 week due to some miscommunication. Even the once a week for 4 weeks was a very, very high dose. And we usually advise against using high doses of the parenteral vitamin D because it is a substance which is stored in the fat and can be potentially toxic. So this patient illustrates what is called Hickham's dictum, which is a jocular antithesis to Occam's razor, where a patient need not suffer from one disease and more than one disease can explain the patient's signs and symptoms, like in this patient. So coming to errors in diagnosis, which commonly are described in both emergencies as well as in inpatients, especially in complex illnesses, the explanations given by clinicians in real life situations is not usually due to lack of knowledge. They usually say, it never crossed my mind. I paid too much attention to one finding, especially lab results. I did not listen enough to patient story. I was in too much of a hurry. I didn't know enough about the disease. I let the consultant or specialist convince me. There are several things like this. There is a beautiful article by Ian Scott in BMJ. And many a time, these are because of several cognitive errors or biases which lead to errors in diagnosis. There is a very big article from Academic Emergency Medicine by Pat Croskery, who is an authority on cognitive reasoning. There are at least 30 types of cognitive biases or errors described in clinical medicine. There are many which are coming up also. I will not go into all of them today. I will just illustrate a few with some examples. The common thing which we see is what is called availability heuristic, where there is a tendency to diagnose by recall of past experience rather than on the basis of prevalence and probability. Like for instance, you have seen a patient of multiple myeloma in the recent past. Every bone pain after that you will start suspecting, and sometimes you may over investigate also. So revisit statistics and prevalence of the problem in the population has to be the mitigating factors in this. The other important heuristic is what is called anchoring heuristic, where tendency to fixate on first impressions, selected symptoms and signs and lab results, rather than going into the full clinical history or the complete evolution of the case. So how to avoid this is think beyond the most favored, reconsider in light of new data or change in course of illness. The third important cognitive error is premature closure, where acceptance of a diagnosis before it has been fully verified by considering alternative diagnosis and searching for data that challenge the provisional diagnosis. This is also called search satisficing. Most of the time, these happen because of maybe we are in a hurry, some investigation has already come or some other clinician has already made the diagnosis and we feel complacent with that. So we always should reconsider the case when refreshed and less distracted. Consider the extremes and red flags. What is the diagnosis I don't want to miss in this patient? So I'll now give examples of these heuristics subsequently. Before that, I would like to go over this beautiful article of Asher in Lancet in 1949, where he counts 7 sins of medicine. One is obscurity, lack of clarity. The other is cruelty, which can be mental and physical. And he says that over investigation is a form of cruelty. in that era, in 1949, he's talking about over investigation. Bad manners in the bedside, over specialization, love of the rare, what is called spanophilia. This is a new term I learned after reading this article. He says common stupidity. Now we talk of artificial intelligence and the natural stupidity. That time itself he spoke about mechanical and mindless following of protocols and therapeutic automatism, where without giving consideration to the other factors, we rigidly follow protocols. And the seventh important sin is what is called sloth, which can be both physical sloth and mental sloth. And in mental sloth, it is reluctance to spend time in detailed history and physical examination. In this article, it is fully humorous. All of you should read it. He says, I've known an eye surgeon after seeing a case of retinitis pigmentosa, write in the notes, this might be Lawrence-Moon-Biddle syndrome. Is there any evidence of polydactyly? For an ophthalmologist to feel himself incapable of counting fingers is surely the limit of over specialization. And prophetically, he mentions in this, and if nothing is done to stop this tendency, we shall have one physician who specializes in the first heart sound and the other who is only with the second. This was in 1949, Lancet by Richard Asher. So every primary general internist, even if he becomes a specialist, should keep the internist alive within himself. It is said that every doctor should be jack of all and a master of one. Physical examination is a necessary ritual. I can quote several examples from my practice. My experience with a thin young lady is still fresh in my mind. This happened some 15 years ago. She had severe acne and hirsutism, referred to me for polycystic ovarian syndrome. She was diagnosed this entity in Mumbai because they belong to quite a rich family, and then came to me. And when I saw her, she looked quite thin, tall, and her pulse was quite bounding. So I auscultated her and found she had aortic regurgitation, aortic aneurysm, impending rupture, sent for emergency surgery after stopping oral contraceptive pills, which she was already taking. So this must have been devastating for the if we had allowed that to rupture. It was a Marfan syndrome with complications in a patient of lean polycystic ovary syndrome. The family actually was devastated that they came to me for hirsutism and acne, but some other diagnosis was picked. But at least it was important that we could address the emergency. And the hospital in which I worked, the surgeon was very good and he did a very excellent surgery on her, and she's still on my follow-up. Now coming to case Vinay 3, this is a 30-year-old male farmer treated by a general practitioner for high lipid levels. The total cholesterol was 280 and the LDL was 210. He was started on atorvastatin 20 milligrams. He also complained of generalized aches and pains and muscle stiffness. After this or even before this, we don't know. He went back to the GP and the GP did a CPK because the patient was on statin. It was 420, marginally elevated. He also complained of dyspepsia and bloating, so he was sent to a gastroenterologist who did a liver function test where the OT and PT were 96 and 84. So he was diagnosed as fatty liver and maybe statin-induced liver enzyme alterations, and some CPK elevation was also attributed to statin, and due to some reason he landed in my OPD. This is his face. From a closer look, we can see the sallow yellow complexion and the typical myxedematous look. And once he opened his mouth to answer his name, the voice was croaky. He had a free T3 of 0.6, free T4 of 0.4, and a TSH of 96, clinically clear-cut primary hypothyroidism with myxedema. So several learning points from this patient: error due to undue focus on individual lab reports without looking at the total picture, overlooking the physical examination, primary hypothyroidism explain all his labs, hyperlipidemia, increased CPK, and liver enzymes. The case Vinay 4, Mrs. SK is a 26-year-old NRI on routine health check was found to have high T3 and T4 and TSH normal. In the outpatient, whenever this preventive health check is done, a general physician sees all the reports, and then because of the high T3, T4, ordered a technetium thyroid scan. The nuclear medicine person asked specifically whether the patient is pregnant or not. So pregnancy was excluded, and the test was also done, and the patient came to me for opinion. The thyroid scan was normal. The history taken by me, the patient has been on oral contraceptives for the last 3 years, which explains her high T3 and T4 and normal TSH, because oral contraceptive pills contain estrogen. It increases thyroxine binding globulin and increases the total hormones, where the free hormones will be normal. For academic purpose, just to show the patient, because she is an NRI, I got free T3 and free T4, which were normal. We had to only reassure her that her lab results are because of oral contraceptive use and there is nothing wrong with her thyroid. So here it brings us to the concept of waste, worry, and the 7 sins of medicine. Asher's report of 1949 was followed up in NEJM in 2020 by this author, Rayleigh, where he said that waste of money and time and the mental worry caused by mindless investigations is the bane of modern medicine. This is Professor Bhandarkar. Most of us would have known him as the co-author of a pharmacology textbook, Satoskar and Bhandarkar. I was fortunate to have him as my DM endocrinology examiner way back in 1990. That time he was the head of endocrinology in KM Hospital, Mumbai. His advice to us as examiner in DM final was, as experts, it should be your mission to clinch almost a complete diagnosis from history and physical examination itself and use minimum investigations to confirm it for optimal care. Your clinical acumen should benefit even poor patients who can't afford costly investigations and treatment. This was really prophetic words, and he was known for his humane approach to bedside clinical medicine. So, what are the various ways we can improve ourselves and the measures to avoid errors? Familiarity breeds not just contempt but also complacency. Review patients whom you are seeing regularly to revisit history and lab tests. Be paranoid. Don't accept everything written in past medical records without verifying. This will avoid the cognitive bias called diagnosis momentum or framing error. Because many a time the medical officers or residents present cases, a known case of, and then the diagnosis is already, they close their minds to explore further. They develop what is called a framing error. So encourage trainees to present cases as they evolve, not with preformed diagnosis. So this is the last case, Vinay. A 60-year-old female diagnosed hypothyroid in some other hospital 5 years ago. Periodic TSH monitoring has been showing low values. Many were less than 0.1. So frequently doses were being reduced and she was clinically worsening with progressive asthenia, fatigue, and anorexia. The perusal of 5 years records, I always ask the patients to bring the whole file right from the first. You may have to spend more time on such patients. Most of our records show that the pre-treatment TSH was, or while on treatment also, the TSH has always been low. And even the pre-treatment TSH was 0.2, T3 and T4 were low, so all low. So I went ahead and did a serum cortisol, which as expected was low, because we are dealing with a secondary hypothyroidism or a central hypothyroidism, which was probably overlooked and was being treated as a primary hypothyroidism. That is why based on TSH, the dose was always being reduced. And this was the patient who had some breast atrophy, loss of axillary and pubic hair. And we did a cella MRI, which showed an empty cella. And when you went into the details of history, it is very telling. She had postpartum hemorrhage 30 years ago, and after that didn't lactate and never regained her menses, secondary amenorrhea. So diagnosis, Sheehan syndrome, postpartum pituitary necrosis, panhypopituitarism, hypothyroid, secondary hypocortisolic, and secondary hypogonadism, which was being treated as only primary hypothyroidism, which was an error. So why this error happened is because of what is called framing of diagnosis, where somebody has written a known case of primary hypothyroidism, you keep on writing the same and then altering the doses. So I would like to conclude that clinical medicine is extremely relevant still. Clinical endocrinologists presently live in a glorious era of immense possibilities for fruitful partnership with basic scientists. To borrow the cricketing analogy, the role of the clinician is akin to that of an on-field umpire. With the technology of umpteen TV replays and a third umpire review at his disposal, the choice is his, whether to use his judgment and experience to make decisions or blindly refer everything upstairs. It will benefit everyone if modern technology is treated as an able ally than as an autocratic master. In intensive care, recently a concept of Zentensivists have come. This is influenced by what is called a Zentensivist manifesto. A group of clinicians in critical care have begun to discuss. It first started as a Twitter movement and later in many conferences to apply key principles of history taking, physical exam, physiology, pharmacology, and clinical research in a competent, compassionate, and minimalistic fashion, thereby avoiding unnecessary battery of tests which are done every day in the ICU in an automaton-like fashion. The term Zentensivist intentionally combines concepts seemingly at odds, Zen philosophy and intensive care, to describe a holistic approach to the art of caring for the critically ill. In the same manner, I thought we will propose a call for Zendocrinology, where endocrinologists, rather than blindly using lab tests, will use them judiciously and sparingly, keeping our clinical acumen intact. So I would say that clinical medicine is not becoming extinct. Definitely it will thrive. The past was great, no doubt, as Vivekananda said, but I sincerely believe that the future will be more glorious still. And this is from my ode to clinical teachers. With several of my teachers listening to this talk, I thought I should reproduce this. The first four lines were from the poem which I wrote in 1982 when I was the first clinical year in Professor C.A.K.'s unit, which was still kept in the ward number 7, I think. But the last few lines I added last year. Toddlers beware in clinical skill, the ocean of medicine unfathomed still. What words can express the debt that we owe for the seeds of our career you took care to sow? Years passed by, we took on the mantle, this is for recent times, to keep clinical medicine in fine fettle. The torch you greats passed onward should glow forever in the march forward as machines threaten to brush aside human touch by the bedside. Empathic care should come to the fore to bring back glorious days of yore. This you can take a picture, suggested reading. These are some important articles, and this is the book which I mentioned, Scott and Stern et al. Symptom to Diagnosis, an evidence-based guide. And these other articles are really very useful, from mindless to mindful practice by Croskery in NEGM 2013, and the other articles as I've already written here. Before closing, this is just a quiz for the students to go back on retrospective thinking. Just given an X-ray, what will you make out? This X-ray of a 20-year-old male, what more information you would like to have, and then ask for relevant history and examination. What will you find? Maybe you can post the answers later in the case conference group. You can take a picture of this. Thank you one and all for the patient hearing.
Thank you, sir. Thank you for such an excellent presentation. I mean, it is, as usual, pearls of wisdom strewn all over, with finally ending with a great poem. And now the floor is open. And those of you who want to raise a question, you can probably raise your hands or unmute yourself and please speak. And Swami, sir, in the chat box, if there are any questions, can you kindly go over and present it to Dr. Murali, sir?
Yeah, let me see. Dr. Murali, I mean, simply outstanding presentation. Thank you.
Thank you. Thank you. It's actually an emotional moment with so many of the old friends and teachers being there. It was an honor actually to be the opening batsman for this important series.
Dr. Murali, let me ask the first question. I'm going to ask the most difficult question. So this is from Dr. Bose. Jack of all trade is a master of none. How can Dr. Murali be master of one like you are? Explain.
So here we don't mean that we would like to meddle or in every specialty. It is that we should know to whom to refer and at what stage we say that it is no longer my domain. So overall idea of a patient will always help you rather than blindly holding on to a patient or referring in the first at the first instance itself, because cost of care is now increasing, and the more referrals you make, the more the patient, and patients feel happy many a time if you examine the patient fully and ask details about every system. They develop the trust in you, and then they come and ask you for knee surgery, whom should I consult? For my liver problem, whom should I consult? They think that you are an advocate for them. You are more like their family physician. So in that way, it will be helpful, even if you are a specialist, if you spend some time in other specialties also.
Absolutely. I think Dr. Rajarajan has a question.
Good evening, sir. It's been definitely an excellent presentation,
Thank you.
and your case reports are very, make me to think of all medical cases. I'm a vascular surgeon.
Oh.
In the era of so-called rampant telemedicine, e-consultation, some they do WhatsApp video calls. What is your advice on the current generation? Because I always strongly believe that, I agree with your clinical examination. For me, checking the pulse is very important. If I don't check the pulse, I cannot, even for any, even venous disease also, I cannot do anything. So I strongly disagree the concept of telemedicine. Some people they do even critical care ICU from they treat patients from here to the US patients also. So what is your
I'm
advice?
I'm strongly against telemedicine. Unfortunately, when we were forced to do it for the benefit of patients during COVID, it was a very brief period I did it. And even then, I insisted that I will see only my old patients on telemedicine, whom I knew already, and I had to make some fine tuning of their medications as far as diabetes or thyroid or other things are concerned. New patients I never accepted on telemedicine because I feel that without talking to the patient, without seeing their body language, their facial expressions, and at least touching them and doing some examination, we will not do justice. In the initial days, when even we were very fearful of touching the patient because of COVID, I used to examine them even at that time. And one patient really thanked me because at that time they thought that the doctors will not touch them. So that period really showed the value of a human touch, which we always discuss from the famous video of Professor Verghese.
Even some physicians say usage of stethoscopes also been. I mean, people don't put the stethoscope also, but still it has got value. Many pulmonologists or even cardiologists or even I too sometimes check some bruise use of stethoscopes, so which also be of useful.
More than the checking the physical signs, stethoscope has been an age-old bond between the clinician and the patient. And usually I tell my patients it is the umbilical cord which connects you with the patient. Even though
Exactly.
they may find that it may be a poetic exaggeration or a over romanticization, that is how I feel.
Right, sir. Thank you.
I am Dr. Natarajan. If I may include Professor Bose, with regards to your question, jack of all trade, I just want to tell you two people who I hold in high esteem. Professor K.V. Trivengadam, as all of you know, the doyen of physicians. And he was my teacher. I was his postgraduate in MD. And I am talking of days 1980, 78, 80. And whenever people used to come to him and ask him for his advice as to what super specialty we should choose and how to go about it, he would say, no need for super specialties. You be a competent physician. You should have inputs into all subspecialties. And that is what is important rather than going into one field. The second person is Professor K. Srinivasan, who is 90 years now. Again, a doyen in the field of neurology and probably the most intelligent of neurologists. Due pardon to others. Not that others are not that intelligent. And everybody knows, Bala knows, other neurologists know. You be a physician first, then you will be a subspecialty. You know medicine, then you know neurology. Before coming to neurology, you should work at least for 5 years in medicine. You won't take it as a DM postgraduate if they are not working in medicine. So this much of importance they were giving at that time, and it still holds good. And still, clinical medicine is any day, it's clinical medicine. I'm sorry for saying that. There are many people who are youngsters, but still, Mondi also is there. Neurology is the queen of such specialties. There are so many disorders, so many findings, and it is clinical medicine. And there is nothing to excel clinical medicine. Whatever investigation you might have, as Mondi pointed out several times, you have to impose the investigations and reflect on it and marry it with the clinical findings. So, clinical medicine is not a dying art. It is very much a living art, and it will continue to live, as Dr. Murali pointed out ultimately. Thank you.
Thank you.
I think Dr. Shivakumar has a question.
Yeah, just comment, Swami, if I may. I think it's an excellent talk. I think having worked in India and having worked in Tanjavur and in Chennai, and then now I'm working in UK, I think this is a very important topic, particularly for doctors everywhere, including the West, because we come across a lot of bottom-up approach. I think that's probably will spread to India as well. The hospitals are getting bigger and bigger. We have a lot of volume of information about the patient, past medical history and everything. I think most Western doctors have this problem of bottom-up approach, and they have practically forgotten the principles of what Atishan used to say. It always used to start with presenting complaint, but if you come to any country in the West, where the clerking typically starts with the background medical problems, and then they go forwards, try to go forward. I think this particular topic, I think, was very well done by Morley sir. And I myself have given this talk at least 3 times in our local meetings, but I may have to update my slides based on such a fantastic array of references. I think we discussed quite a lot, myself and Morley sir, about this particular topic, but the references he had quoted go well beyond what I had in my content, particularly the Lancet one I wasn't aware of. I think this is still one of the papers I have got in the table is the 2013 New England Journal of Medicine. I have it on my table because that's probably one of the best articles as a physician one can read, the famous New England Journal of Medicine. The other point someone mentioned about Dr. K. Thiruvengadam, I think though I was not a student, I used to, when I was doing MD in Chennai in Stanley, used to work in Railway Hospital. And we used to go to Railway Hospital for his classes. And he used to make one statement almost on every class. He will mention this one. And he will say, I think you should never go back to the patient second time for any checking. That means you should be so thorough in your first attempt, examination and everything, asking questions. That should be the concentration you should be applying at the bedside. The moment you go second time to the patient and ask something or examine something, the patient loses the rapport with you. I think it's very, very difficult not to do that, but I think it's worth, pursuing that aim. I still try to do it, but I think it's very difficult. I think thank you very much, sir, for a wonderful presentation. And I never met you during, I don't know which batch you belong, but I never met you in the college.
1978. So you came, I think, after I left.
1986. So I think it's such a huge loss. I have never met you, but it's a fantastic presentation. Thank you very much, sir.
Thank you. Thank you.
Swami, Swami, this is Dr. Radhakrishnan from Chennai.
Yeah, Dr.
Plastic surgeon.
Yeah, please go ahead.
Swami, it's a fantastic talk. Only thing is I could just get in after finishing a surgery. So I would like you to have the recording of Murli sir's talk. When I was just entering the college, Murli sir just left, but I used to hear a lot of things about him from my teachers there at that time, and also the librarians in Tanjore Medical College. The librarians used to tell a lot of stories about Murli sir. Used to be called as only Pusta Murli sir only, and really proved it. And not only me and my son, who is in the final year, is watching. He says that I would like to go to him for classes. He says. So such a fantastic talk, sir, and covering all generations. And really, you have, I mean, the umbilical cord analogy, you always used to remember, sir. Whenever I think you have I think you have told it same thing in some other this thing also, meeting also. I still remember that. And very thankful to you, sir. Thanks a lot.
Thank you. Thank you for the kind words.
Yeah, and the recording, Dr. Venkatesh will make it available to everybody.
Yeah. Thank you, Swami.
Thanks, Dr. Murali. Dr. Ravi from Trichy.
Hi, Ravi. How are you?
Yes, fine, sir. So it was really nice. In between, I had to leave because of some work. So then I am back now. So I hope it would have gone well. I would like to see the recording because I could not completely see the entire talk.
Yeah, I think it'll be made available, Dr. Venkatesh.
Sir, we have actually created a TMC Medalog YouTube channel. So it will be named TMC Medalog. And once all these talks will be uploaded in series as they happen.
Sure. Thank you. Thank you so much, sir.
If there are any more questions or comments?
Murali, this is Captain.
Sir.
Thank you very much. Wonderful, as usual.
Thank you, sir.
That poem is still, till I was dean there, it was in ward number 7. Oh, then they changed the number and all now. Still, I remember that poem. Now you have added something in the last 4 lines. And the neurology, one more, somebody was telling. In the history and clinical examination, you can make a diagnosis of what is the lesion and where is the lesion. This is by Professor P.A. Bhaskar. Thank you, Murali. God bless you.
Thank you, sir. It was very kind of you.
Thank you.
Dr. Bose here, Murali. It was a very excellent talk. Like, I really enjoyed your talk throughout, and I was there completely watching it, because I always feel that most of the surgeons think that you directly go into robotics without any haptic feel of the patient. This has been a very common thing now, because they say you don't have to get trained as a general surgeon and you go directly into robotics. So this is why now we have a lot of specialists coming up, and you see that a single patient is attended by multiple surgeons, especially when they undergo surgeries in the abdomen. Because, you have a hepatobiliary guy, you have a gynecologist, and you have a urologist, 5-6 people attending on a single patient. So this has been a very common feature in surgery as well. So I don't think surgery is any different from neurology as well, because I think we still would appreciate a surgeon to examine a patient completely. And whatever you said in your talk applies to every specialty. And I wanted to insist on that. And I appreciate you for the first talk, which was a very excellent one. And I'm sure Dr. Swami is here. I think he would give us a very nice talk on what research is about next time. So thank you very much. And I thank Dr. Venkatesh for doing this. And I appreciate his initiative. Very well done, Venkatesh. Thank you very much.
So I think I've got the next person to talk. So Swami sir can't really refuse. Despite his busy schedule, I think I'll catch hold of for the next talk. Thank you so much, sir. Thank you. Sir, Murli sir, I have one question.
Yeah.
Professor Bose just said that clinical medicine is inevitable for all specialties and indispensable. But do you feel that in this modern era, are there any specialties which is an exception where clinical medicine is probably not the way to go about?
No, we can't say that because that means that we'll be straitjacketing patients to individualized compartment system. Every patient finally has likely to have other issues also. That is why I love endocrinology, because if you know diabetes, you know the whole medicine. That's what they say. Earlier they used to say, if you know syphilis, you know the whole medicine. Now they say, if you know diabetes. So one way you win over the trust of any patient is if you look at him as a whole rather than through the whole. And unfortunately, now we have interventional specialties which are doing wonders, no doubt, but the human element is missing and somebody else has to take care of it. And we don't have the generalist or the family practitioner nowadays. Patients themselves are preferring to go to specialists, which is again very unfortunate. So I think to win the trust of a patient and even to cut costs and knit the whole picture together, many a time we may find something which is much simpler than what you have been doing in a roundabout fashion through investigations. For instance, how often we have seen patients who have almost on the table for lumbosacral discs surgery because they complained of left lower limb weakness, whereas the lesion was in the cerebral cortex. You have not examined the patient as a whole and you just went by the MRI which showed the disc. So every specialty will have several examples like this, and if you look at the patient as a whole, then definitely our investigations and treatment will go in the right direction.
What are your thoughts in this day and time of AI, sir? Do you think they will supplant doctors eventually?
AI will be definitely useful for us. Maybe AI will be another talk. Every specialty we may have, you may line up talks in future, role of AI in different specialties, and each specialist, subspecialist may be asked to give a talk. AI will definitely have a role because we know that AI does pattern recognition very well, and volumes of data which it can handle are much better than what a human brain can handle. So in that way, diabetic retinopathy has already come in a very big way, especially in providing care to outreach programs in remote parts of India, where the fundus photography is captured on a simple mobile and transmitted to Chennai or Hyderabad, and there they are looking at AI, and you can at least uh, cut short the time, 5,000 images viewed, and then which 100 patients of them have to be called to a good ophthalmic center for further, and others can be just advised follow up. In that way, AI will definitely help us, provided we know how to use it judiciously and rather than as an ally than as a master.
Thank you, sir.
Like for instance, in hyperaldosteronism, now we have AI tool. We have a mobile app also, where you feed the renin, aldosterone, and then the patient's age and all, and it gives a reasonable this thing whether you have to go for adrenal vein sampling or you can go for surgery. These are all things which are being worked out. Every area people are trying to bring in AI for the benefit.
Are there any further questions or comments?
Murli, can you hear me?
Yeah.
I'm Dr. Balasubramanian, your classmate.
Hi, Balu from Kumbakonam.
A wonderful talk.
My
Yes,
neurology
wonderful
teacher.
talk. Wonderful talk. I have just one comment. So nowadays we are seeing cardiologists and neurologist giving their prescription and forgetting they are basically general medicine, but they are asking the patient to go for diabetic consultation to some other diabetologist. And for example, the patient is having some bronchial asthma, they'll turn to the respiratory medicine. What do you think about this type of practice? The neurology should not see coexisting cardiac illness. Cardiology should not see the coexisting diabetic illness. Nowadays, in the corporate sector, once the patient enter, the cardiologist will take over only cardiology. The rest of the part should be taken by the other doctors. Do you think this type of practice will be injurious to the patient or comfortable with the doctors? Because suppose I'm going to see a patient who is coming from a corporate hospital, they say, sir, for neurology, this is my prescription. For the diabetes, this is my prescription. For this hypertension, this is my prescription. For my bronchial asthma, this is my prescription. And they are very much confused. And not only they are confused, we are also confused because all the doctor died one vitamin. See, like that it goes on. So how to stop this type of practice?
So this is unfortunate, but the patients also have to face the blame in this because nowadays patients prefer. Many a time they tell when I am trying to advise on antihypertensives, they say you leave it. My cardiologist is seeing it. They interject. So there are patients who respect you that you will, they trust you that you can give an overall opinion, but majority they now prefer to go to different specialists, and that is probably it's a vicious cycle. We have engendered this vicious cycle by promoting this culture. But what you say is very true, and I know in addition to being a neurologist, you are a very good internist, and in your hospital, you try to look at everything as a whole because you run your own hospital. Whereas in corporate sector, there is pressure probably to refer, cross referrals, earn them revenue. Plus, there is a role of defensive medicine also. Suddenly, if something happens, that something may not happen, but you always want to be on the safer side. Every clinician has to have a dividing line when exactly my role stops and when I should refer. So there are already guidelines in every specialty which diabetes should be referred to an endocrinologist or a diabetologist and which can be managed by a generalist. In the same way, nephrologists, they have guidelines when exactly at the start of CKD, the internist should refer the patient to nephrologist. So finally, we all mean the patient should receive the best care, and many a time we feel that the modern advances or recent advances we may not be able to cope, so it is better to refer to the authority, even though it may not be good for the financial aspect of patient. Like many a time patients come to me with SLE and tell me, why don't you treat yourself because you know medicine also. But I politely refuse because SLE is one disease which I know is quite dynamic, variable. There are newer advances in treatment. Anytime any complication can develop. So it's always better that they go to a rheumatologist, or if there is a kidney problem, go to a nephrologist rather than me trying to hold on to it. So finally, we have to take a call at what stage you would like to refer.
Thank you. Thank you. Thank you.
Dr. Bala, good to see you after a long time.
Thank you, sir. Thank you, sir.
Good to see Balu sir at this time because usually he is asleep by this time.
At OPD at 4 a.m., 5 a.m.
I've seen his clinic, it's very busy.
Sir, I just, Swami, I just have a question to Dr. Murli, sir.
Yeah.
Sir, do you think that AA, the present AA or the current AA or even the future AA will look at only patterned observations or given an abnormal situation like how to act and other things? You think that will be possible?
It all depends
Because
on the
inputs.
algorithm, the inputs, and for
Yeah.
that we should be clear what we want from it.
Okay.
So definitely large volumes of data, pattern
Okay.
recognition. That is why AI will be very good in radiology, will be good in image interpretation, fundus
Okay.
photography. But the human element, I think, will be definitely missing. That is why we should use it as an ally, and we should know when we have to intervene rather than blindly follow it.
Okay. Thank you, sir. Thank you very much.
I think AI will be definitely a hot topic for future. There may be many talks on AI, maybe depending upon different specialties, radiology, how he views it, or a cardiologist, how he views it.
There are so many questions in AI because all of us are a little worried that probably AI will take over.
No, I don't think it will take over. AI can't do what we do.
Yes, yes, sir.
Actually,
And it is like a teamwork, like how they do in cancer now. Everybody understands that they have to have a cancer team where a surgeon, physician. So AI is also like a teamwork where the inputs are from different people and it is a collective input. So even if you are in a team, ultimately the decision has to be taken by probably the surgeon who is going to do the surgery.
It will
So
definitely
like
help
that.
us to
Can I
coordinate.
reduce the volume, please?
Yeah, actually, in collaboration with the London School of Hygiene, IASC is hosting an AI for clinicians, April 8, 9, and 10.
Oh, okay.
So it includes like it's going to be coding and all that, It's going to be a part of our life.
So we can't run away from it. And they say the modern, the illiterate will be someone who is technology illiterate.
Can I just make a comment about AI?
Yes.
Oh yeah, I think that I mean, as you said, it's never going to replace it. But there are huge challenges, particularly with as the AI moves from machine learning towards generative AI and well as conscious AI. I think what's happening with generative AI and conscious AI is going to decide whether it will replace the doctors or not. But I think the conscious AI is about how sort of emotions it can display. For example, when we come across a sort of a patient with a terminal diagnosis, of course, sometimes we may not be able to speak to them, and every doctor would have faced the situation, but AI probably may not be able to do that. I think that's a huge challenge, but I think we all have to be careful. I mean, it's still there's so much advancement is happening in AI. I think these two things are going to decide the generative AI and the conscious. Generative AI is already there. It can generate new data without necessarily relying on volumes of data. It can generate its own hypothesis. It can test itself, and it can come up with solutions and problems and so on. Yeah, I think it's a very interesting, challenging area. Yeah, thank you.
You're good. And any other questions? There are no questions. Dr. Venkatesh, maybe you can wrap up.
Yes, sir. Sir, thank you so much for all my senior professors, teachers, and it was so nice to see everyone face to face. And that has been tremendous. And I must thank Professor Murli sir for honoring us with this excellent disposition on a very important topic, which probably must be introduced for every third year clinical student and must end in the final year with a similar wrap up with such a kind of a talk. And for posterity, this will be preserved, and this will be one that will be remembered because the TMC Medalog series has begun with such an excellent talk where there is a fusion of clinical medicine and the value of clinical medicine has been emphasized so beautifully. And in a typical Murli sir style, he has punched it with so much of excellent, language, and that is really something which is remarkable. Thank you so much, sir. Thank you for accepting and honoring us with this kind of brilliant talk. And I would also thank Professor Swaminathan sir, Professor Captain sir, and Dr. Rafiq for all being there and introducing this inaugural session. And I believe that we will be moving it forward. And I also use this platform to make a sincere request to all our experts. Please kindly come forward to share your expertise with our youngsters, particularly, And this will be a tremendous, I think, in due course of time, all these talks will receive much wider audience. At some point of time, we were 52 who were logged in, which is excellent. I don't think so. I've been part of so many webinars where I've seen the inaugural sessions. I've never received more than 20 or 30. But I think TMC started with a bang. We started with 52. That's wonderful. I think it's a very satisfying day for us. So with that, I think we will call it a day. And thank you once again for all of you for patiently listening and your participation. Thank you so much. And I think with that, we'll call it a day. Thank you, sir.
It was my pleasure.
Thank you. Bye-bye.
Thank you, one and all. Bye.
Thank you.